OCT angiography. Is it ready for the glaucoma clinic? The technique of OCT angiography for studying optic nerve head perfusion was first described in 2012, prior to which its use was mainly explored in retinal pathologies. OCT angiography is a non-invasive technology which uses the principle of motion contrast to identify blood vessels of the optic disc and retina. It does this by performing repeated OCT scans of the same area. It uses variation in the OCT signal caused by moving red blood cells to delineate blood vessels. Algorithms then calculate the vessel density, which is the ratio of the area occupied by blood vessels to the total imaged area, reported as a percentage. Vessel density has been shown to be a repeatable measure in glaucoma eyes with a test-retest variability of approximately 6%. This is an OCTA printout of the disc which contains the vessel density map, the en-face image, a heat map of the vascular network, and a table of calculated vessel densities. The B-scan images show the segmentation for the chosen slab. This is an OCTA printout of the macula showing similar zones. One advantage of OCTA is that the vessel density can be calculated separately for the superficial and deep layers of the retina. Scanning regions similar to OCT were evaluated in initial OCTA studies. Unfortunately, the optic nerve head was not ideal for vascular imaging due to its variable geometry and shadowing from large blood vessels. The radial peripapillary capillary plexus and the superficial vascular plexus of the macula showed good repeatability. These are imaged in glaucoma patients as they supply the RNFL and the ganglion cell layer. Whenever a new technology is introduced, it is important to establish that it provides some additional information over the standard tests prior to use in our clinics. Hence, we have methodically evaluated the usefulness of OCTA in glaucoma patients by addressing the following questions. The first question we asked was, is the vasculature affected in glaucoma? And the answer was a resounding yes. Vessel densities are reduced in glaucomatous eyes when compared to healthy controls. The second question we asked was, when does this reduction in vessel density occur? We know that the structural changes in RNFL precede functional loss on visual fields. Do vascular changes also precede visual field loss? We conducted a cross-sectional study on open-angle glaucoma eyes with defects restricted to one hemifield and studied the RNFL and vessel density changes corresponding to the perimetrically normal hemifield. We compared these vascular and structural measurements with those of healthy eyes. We found that within the perimetrically intact regions of glaucomatous eyes, not only was the mean RNFL thinner, but the vessel density was significantly reduced as well. Hence, the reduction in vessel density occurs prior to visual field changes in glaucoma. The next question we explored was the diagnostic ability of OCTA. Most studies have found that the diagnostic ability of peripapillary vessel densities and RNFL thickness in glaucoma were similar. Depending on the severity of glaucoma patients included in these studies, the area under ROC curves of both peripapillary vessel density and RNFL thickness have ranged between 0.85 and 0.95. In the early stages of visual field loss, the sensitivity of RNFL thickness was better than that of vessel density for fixed specificities. However, interestingly, in later stages of glaucoma, the diagnostic ability of peripapillary vessel density appears to be better. Studies comparing the dynamic range of these two devices have shown that OCT RNFL reaches a measurement floor at about -15 decibel, after which there is little change in RNFL thickness despite increasing glaucoma severity. In contrast, no such measurement floor was detected with OCT angiography. This suggests a potential benefit of OCTA in the monitoring of advanced glaucoma. The obvious next question is, what about progression? In a cohort of primary open-angle glaucoma eyes with disc hemorrhages followed up longitudinally, we have shown that OCTA is able to detect peripapillary vessel density reduction. Similarly, other groups have shown significant macular vessel density reduction in glaucoma eyes over a 12-month period. Hence, OCTA is sensitive enough to diagnose progression. But can it also predict future progression? Several groups have also shown that lower baseline peripapillary and macular vessel densities were associated with a significantly faster rate of RNFL loss in glaucoma. Eyes with a baseline vessel density of less than 50% on macular OCT scans showed significantly faster RNFL decline than those with vessel density greater than 50%. Therefore, vessel density provides useful information about the risk of glaucoma progression. Apart from this, a new OCTA biomarker for glaucoma has also been identified. Microvascular dropout is the complete loss of microvasculature in the deep retinal and choroidal layers of the parapapillary zone, which is seen in almost 50% of eyes with primary open-angle glaucoma compared to none in controls. The presence of this microvascular dropout was found to be independently associated with progressive RNFL thinning and hence is also a biomarker for glaucoma progression. What is the main limitation of OCTA in progression analysis? When analyzing OCTA scans serially, one must account for changes in signal strength index. Vessel density is significantly greater in scans with higher signal strength index, and this must be factored into any longitudinal analysis. To conclude, OCT angiography provides unique information about vascular changes in glaucoma and aids in its diagnosis. OCTA may be useful in identifying glaucoma progression, especially in advanced disease. It also provides biomarkers about the risk of future progression, which can help us appropriately plan the management for our patients. Hence, it is time we start incorporating OCT angiography into our glaucoma practice.